And okay, so thank you all for joining from all over the world and from on time zones. Today's meeting. The first speaker is Dr. Massimo Corain from Italy, corrections of post-traumatic forearm deformity in children. So please go ahead and please share your slides.
Okay. Thank you, Takehiko, for thank you to all the PULM for the kind invitation. And can you see my videos? Yeah.
Yes.
Okay.
Please go ahead.
So this is the session of today. I only show 2 slides to introduce myself. This is the group that some years ago see me, Taki, and a larger group in 2017 during the International Travel Fellowship in the US, and in 2022 in Verona for a FISOS meeting that we had and I had the honor to organize. My name is Massimo Corain. I'm head of surgery microsurgery unit in Verona University Hospital in Italy. I'm chair of the FESH Clinical Practice Committee that included the Hand Trauma Committee and Green Committee, and member of the board of the Exam Committee for European Diploma in Hand Surgery. And this is Italy in the south part of Europe, and Verona is my city, so these are some slides of Verona too, sorry. This is the hospital where I work, is a university hospital, and this is the children hospital where I do pediatric surgery. That is a building very close to the first one. Our center is a 24/7 day for microsurgical traumas. Is a European hand trauma replantation center, and is a pediatric hand reference center and IBRA center too. So we are going to speak about the correction of post-traumatic forearm deformity in children, which are normally symptoms that carry us to consider this deformity. Normally, patient comes for loss of pronosupination, loss of grip strength, pain, above all in the ulnar side, and sometimes for cosmetic deformity, which is the best timing, the best time to treat it. The best time is that the sooner we do that, the better result we'll have in future. So don't wait for mature age if we are approaching a deformity and a Nash malunion. Osteotomy may be contraindicated if we have a light deformity, no symptoms required by the patient to be corrected, a good compensation of the movement, and soft tissues retraction for severe trauma can require more than one step for surgical correction. Important for pre-op planning is to do obviously an X-ray and a contralateral forearm X-ray, considering that the forearm is the complex of motion that include the wrist to the elbow too. So we have to consider all the forearm with the 2 joints at extremity included. So the TC is very important to consider, and the 3D TC, 3D printing models has been used, and I will show you some cases later. And patient-specific implant, the PSI, is the most recent technology that helps us to consider the correction of these deformities. Some devices that can be suggested during this surgery are a reduction pincer and a spreader that helps to keep the alignment of the bone while we are going to fix it. And I use a piezoelectric surgery because it reduces the risk of hitting the site of osteotomy, and we have much less problem in healing time for osteotomy. Dealing with the 3D planning in these cases, we consider that it helps to understand in a better way the old fracture line. It helps to confirm the best site of osteotomy, and we can plan before surgery how to do it. And we can choose the best device, above all if we don't are approaching with a custom-made plate, and show us the precise position on the shape of the grow plate during growing age. and it's a great means of communication for pre-op dialogue to the patient's parents. So these are some images of the pre-op planning with the 3D models in 1:1 scale that I had to use during the last years. And there are different possibility of materials. And I'm going on with this presentation with some case series in order to show the last cases I did with the forearm and the evolution of the approach for the correction of the forearm deformities. This is a children, now he's 12 years old. When he was 4 years old, had a wrist fracture. And this is the CT that shows us I measured 52 degrees of deformity and no presence of ulna plus and a partial fusion of the grow plate. And this is the 3D printing model in a 1:1 scale that helps me to consider in a better way the line of the grow plate and to choose the plate. This is before the possibility to have a custom-made plate. So we are dealing about 5-6 years ago. In these cases, I used a distal ulnar plate, and these are some steps, surgical steps for correction of partial correction of this deformity. And this is the follow-up after 1 year with a good consolidation and waiting for a final correction after the growth. I show you a second case I call the evolution because when the patient was 10 years old has a missed Solteraris type 1 fracture. And after 1 month since fracture, it has been treated in order to consider a correct reduction, a temporary fixation with the K-wires after 1 month. And this is the result after 2 months with a partial fusion that we can see on X-ray. But after 7 years, the patient is now 17 years old, has this hypometry of radius with a partial fusion of the grow plate. And this is the functional and clinical aspect of the form. The CT that show us the condition, a 3D printing model where on it I can consider the osteotomy line to see in a better way the grow plate that is remaining, and I measured the variance of 28 millimeters. I consider to do an osteotomy. I choose the plate, and these are some intraoperative surgical plates with the landmarks with some K-wires in order that help me to measure the distance to the joint and the osteotomy line that I've planned before the piezo surgery. A distal ulnar plate that was useful in these cases because I could use 3 screws in the distal part of the osteotomy. What is necessary is not to overstress the osteotomy side more than pre-planned, or we can't fix the plate with the screws. And I associated a percutaneous distal ulnar epiphysiolysis in order to try to reduce the growing during the next future of the bone. And this was the partial correction that I could had with the internal synthesis. After after 2020, we have the opportunity of a PSI, so a patient-specific implants and a customized plate and a 3D planning. And this help us to reduce the surgical time and to achieve good results in a difficult non-everyday situation. And this is the same case we saw before. Now he finished the growing age. He is 19 years old. This is the clinical aspect. But now we have the PSI and the possibility to make a digital planning and to have a custom-made plate. So this is the situation compared with the reference, the contralateral forearm with a TC is possible to plan it. We check a 30 millimeter of hypometry. And I decided to associate a shortening ulna and a lengthening and correction of distal radius. This is the digital simulation of the correction, the template that are sterilized and we can use during surgery that helps us to consider exactly the site of osteotomy and where fix with the screw and the plate too. And these are the simulation of the correction, the graft shape that we have to put inside the osteotomy line and the pre-op. And this is a custom-made plate. You can see the dimension and the shape of a custom-made plate that is much different and much more adapted to the deformity we have to correct. And this is the simulation or what we are going to do. These are some intraoperative steps with the osteotomy line with the piezo surgery is very clean osteotomy. The whole of the pre-drilled screws and the spreader to connect to align a distal ulnar joint. I associate a ulnar shortening osteotomy, and this is the follow-up after 2 months of good correction of the joint inclination, and after 2 months we have a good stability with the patient that is going to restore the much movement he can. This is another case of a forearm deformity, is a sequel of osteomyelitis at radius. Now he's 10 years old. The story was not clear about this patient. Maybe when he was 2 years old, the parents said he had a trauma with a radius lasis. This is the X-ray check, the TC with the digital simulation of the situation. And what I decided to do in this patient was a one bone forearm in order to give good stability and a good alignment of the wrist that had a good range of motion. And I simulated with the digital planning with a custom-made plate. I need a plate that has to be long enough to stabilize the osteotomy and with the 4 screw in the distal part of the osteotomy. So this is the planning, the guide, the ulnar osteotomy with its guide, the simulation of the stabilization of a one ball forearm. Okay, all the screws. And this is the radiological and clinical aspect after a few months with a good result in terms of alignment and in terms of range of motion of the wrist. Another case is a forearm post-traumatic deformity. This patient, when I was 8 years old, so 10 years ago, had a fracture of the proximal radius. These are the images that we can have with the normal TC and show us the deformity in the proximal part of a radius. And the pronosupination is very lack, it's around 10 degrees, it's not so large. And with the digital evolution of the 3D and animation, we can consider the exact part of the deformity, but only with the PSI we can check it and measure exactly how we can are going to approach. And so only now we can see that there is associated an ulnar deformity too, lighter than the radius one. But if we are going to correct only radius, maybe we can restore a perfect alignment of the forearm, because during the growing age, the ulna often is tractionated by the soft tissue like the interosseous membrane. And so we have to consider very often to correct radius, that is the original sequel of the fracture, but ulnar too. And so that we planned with the double osteotomy. And we have a very precise distance from the joint in order to consider where to do osteotomy. These are the custom-made plate for radioulna and the template to fix it, the simulation of the final correction. And this is an intraoperative movie that show how fixed and how stable is the template on the ulna before to go to drill it. It is only stabilized with some plastic wing on the bone, and the K-wire is only to give the distance to the joint that we have planned before. This is after the template removal with all the holes of the plate and the osteotomy line made with the piezo surgery, the postoperative check, during which I suggest always to make a sort of a check of a pronosupination to be sure that there is no impingement between the bones and the plate that is not so easy to simulate with the digital pre-op planning. And this is during the follow-up with a lack of pronation, but a good restore of the movement. I'll show you the last case is an atrophic multiple non-unions forearm deformity. This was a sequel of a forearm trauma with probably osteomyelitis when he was 8 years old. This is not very old, the story of this patient, this young patient. She had 4 surgeries. I show you some images of the tentative to stabilize and graft the ulna bone with unsuccess, several plate breakage, and non-union of the graft in the ulnar part. So in this case, I decided to go for a digital planning and a fibular vascularized graft. But with the deformity of the ulna, only with the digital plan, I can realign and measure exactly the length of the ulna and where the holes of the previous plate are in order to avoid them. This is the graft that I'm going to plan, and a custom-made plate that is very small, but with the typical shape to go and fix with the most screw I can in the distal and proximal part of the graft. We made a simulation also for the fibula, and these are some intraoperative steps with all the template and the custom-made plate, the fibula with its template that shows where to cut exactly. And this is a follow-up image with a good consolidation, obviously a partial restoration of the joint, but with a very long story of non-union. So I consider that in patient-specific implant is a recent technology with a good cooperation between engineer and surgeon, is easy to obtain because our online meeting is a great help to understand the deformity side and its entity. Custom-made plate where no indicated are pre-modeled on the correction, and in my opinion, the indication has to be not in all the cases, but in most severe distal radius deformity and forearm deformities and in some congenital deformities. This is a slide. I'm going to invite all of you to the midterm IFSH that will be in April 27 in Venice. Italian Society has this great honor to help in organization, and so you all are invited. And I have the task to create a group of pediatric surgeon expert worldwide, and will be in contact, and we speak about congenital deformities and post-traumatic sequence. Thank you.
Okay, thank you, Massimo. Very, very interesting. Thank you for your clear explanation with several actual cases. Any questions from the audience?
Yes, we have one question in the chat.
Okay.
Okay, I see the question. Thank you. When there is no contact between the bones, I prefer to graft it. I don't graft if there is a wedge osteotomy, with open wedge osteotomy with a cortical that has contact. But if we have a gap, I prefer to graft it. In some cases, I use the synthetic substitute, But during the last cases, I'm going to use the hip if I can, the iliac crest, sorry, because I had some problem of absorption of synthetic graft with the 2 cases.
Okay, any other questions? Do you simulate the 3D planning using any specific softwares? Do you have any softwares to plan this 3D and make custom-made device and plates? Use a software.
Sorry?
He said if you need a specific software for the 3D planning.
Sorry. No, you don't need it. The software is of the companies that normally help you to realize a custom-made plate and digital pre-op planning. So you need a platform to share with them the video, like Meet, but they do everything. It is not cheap, but is becoming cheaper and cheaper because of the use that is wider and wider worldwide.
Okay, thank you. Any other questions or comments? Okay, thank you very much. Thank you.
Thank you.
Massimo.
Thank you.
Okay, let's move on to the next speaker, Dr. Wee Lam from Singapore, operating congenital hand conditions in adults. Okay, yes.
Okay, thank you so much. Let me just get the slide up. You can see, yeah?
Great. Yes. Thank you.
Yes.
Okay, so thank you very much, Takehiko and Paco, for inviting me to give this talk. As Takehiko said, a few of us just came back from the ASSH in Vancouver. I landed this morning, so a little bit jet lag. And before that, I was also with Massimo in Milan. So it's just a few weeks of traveling, but glad to be home now. So when we talk about operating on congenital hand deformities in the older or adult patients, we need to first of all define what congenital means. Congenital means that the deformity is present at birth. So it should be quite obvious to parents and the medical staff that there is a congenital deformity. Of course, it's not always that obvious. But the implication is that care should be given from the time of birth. That is the expectation. However, this doesn't always happen, and therefore the congenital hand deformities may present late. So now this has been a very, very broad topic to prepare. It's so many areas we can look into it. We can look at 3D printing, like what Massimo has already talked about, in the older child or adult. And it effectively is looking at almost the entire range of congenital hand deformities. So what I try to do here is try to frame my talk in the form of 5 questions. And I hope to be able to provide some answers. I don't think we can answer all of them. So the first question is whether congenital hand surgery in the older adult patient really means that they have presented late. Now, the word late implies that there is an ideal time to operate, which is as early as possible. Now, however, when you look at the literature, there really isn't a consensus on the best timing of surgery in congenital hand differences. Everybody has got their kind of the best time to operate, and opinions really differ between surgeons to surgeons. However, in this letter to the editor, I told them that the information we have right now only qualifies as a letter. It cannot be a review article. We need much more evidence. But we surveyed the UK surgeons, and this is sort of the consensus on the best time to operate on different conditions. We came out with this consensus because of COVID. A lot of congenital hand deformities were neglected. That's why we decided that it's really important to have some form of consensus. But really, there are no consensus in the literature on the best timing of surgery, and therefore it's very difficult to define what late means. Generally, earlier surgery is considered better in children because of cortical adaptation. For example, we know that polysization in the adult patient doesn't work very well because the brain doesn't adapt very well. If you operate earlier, you allow better incorporation of hand prehension. So in this amniotic band, nobody will argue that that we should release this as soon as possible, and this should have been released earlier in this older child, so that the thumb can come out and the brain can start to develop a thumb index finger or thumb digit prehension. If you operate earlier, there should be less disruption from school, there should be less scarring, and theoretically the child should remember less. So earlier surgery should be considered if possible. Then we got to look at what actually makes the child present late or as an adult. So there are several factors for this. So now this is sort of in my own practice in the UK with good infrastructure. Now with this good infrastructure, 54% are still seen within 3 months. That means you are looking at 46% they are not seen within 3 months. But generally by a year, 88% will be seen. However, we can understand that there's still quite a lot of children that are not seen within 1 year. And this is in a very, very good infrastructure like the UK. Now, I do a lot of work in low resource countries where the infrastructure is poorer, and you can imagine that a lot of children therefore will present late because the infrastructure is just not there. Yeah, there are other reasons why a child may present late. There may be other health problems. So this child is 4 years old. He had Pierre-Robin syndrome. That means he has airway issues, and therefore I couldn't centralize his wrist earlier. And by that time, he's developed an ulnar prehension. I could still do something to his other hand. I could still polysize his index finger, but I decided to leave this right wrist alone. Now, the parent may have been given wrong information. So this child that I saw was told that nothing can be done. The parents were told that nothing can or should be done, and the hand should be left like this. And of course, this is not true. This syndactylis can be divided, but the surgery may be much more challenging as the child gets older. Sometimes there's a conflict between the parental versus the child wishes. This 18-year-old boy came and saw us independently because the parents refused to let him undergo surgery, because especially in the Asian culture, an extra thumb is considered a good luck thumb. And so there are many adults walking around in Asia with an extra thumb that is not corrected because they don't want to lose their good luck or their blessing. This 23-year-old lady came and saw us. She has Fanconi anemia, so she did have other health issues. But the main thing is that her mom refused to allow her to have surgery when she was younger. And then her mom passed away recently, and so she presented. Now, the challenge of operating in an adult is that you really gotta make sure that what you finally give the patient is better than what she already have. Expectations may differ, and there's no chance for growth or catch-up growth to correct itself. So in this case, we did a neurovascular island flap, and I think the result is better than what she had previously. Now, when we talk about an extra thumb being a good luck thumb, this is really taking it to the extreme. This child with mirror hand, therefore, has 8 digits, and because of that, the grandmother refused surgery because not only, he doesn't have a good luck thumb, he actually has 4 good luck fingers. And I couldn't advise the family to let the child undergo surgery. So there's all these cultural or aesthetic reasons that we need to think about. This 25-year-old came, and I was very surprised that she was bothered by her camptodactyly. This is in a low resource country, and we just gotta be sensitive that it doesn't matter where you are. People have their reasons for seeking surgery. Then obviously there are late complications of previous surgery. We all get this. This is one of my earlier patients. following thumb duplication surgery. So sometimes we do have to see them when they are older until skeletal maturity, or a child may manifest late. This is another example of an operation done in another hospital, wet creep, which again we all see from time to time. In terms of late manifestation, I think the best example is Madelung's deformity, and often children do not present until they are teenagers, and it's probably the first time they have been diagnosed with Madelung's deformity. I think we all have experience of that. So these are the reasons why a child may present late or as an adult. Now, next question to really address is late presentation always a problem? Now, there are extreme cases. So this, I think she's 17. She presented with this constriction band, wrist drop. I think even if you release that early, you may not correct the wrist drop. But in order to solve this aesthetically, it's a lot more difficult as an adult. Now, this is something you really should not see. He presented when he was 10 with bilateral APERS. And his prehension is one really that is quite difficult for him to use his hand. And so we started surgery when he was 10 in order to get him the first wet space, and then slowly separated all his fingers. So late presentation may be a problem in certain cases, but it may not be a problem in other cases, because children have a remarkable ability to adapt even into their adult years. One good example is radial dysplasia. So in this older child, you can see that she can bring her hand to her mouth. So I will be very hesitant to operate on her wrist. She has thumb hyperplasia. She really has no problems at all. And so again, I'll be hesitant to do an operation. Now this is an 18-year-old man with bilateral radial dysplasia. And again, we got to question ourselves whether we really need to centralize the wrist when he's so functional and is adapted so well. Now, I had the privilege of seeing a lot of patients who had thalidomide or whose mother had thalidomide when they were babies in their wombs. When I saw them in their 20s, they were treated in the 1960s. And then I saw them a few years ago when they are now reaching their late 50s and 60s. And it's just very interesting to see how they've adapted. So we have often been thought that if we have a hyperplastic thumb, that we should really polysize the index finger, because that will give you the best function. In some of these children, they will not polysize. So you're looking at their hand, you're thinking, oh, if only they had a polycization, and therefore the hand function will be so much better. Until I assess their hand function even more. This is the index finger, and just to show the incredible adaptability of the finger if you leave it alone. And I'm not really sure that this is a polycization will necessarily be better than what she already have. So it's just something to bear in mind, because we don't see a lot of these patients when they are much older, and many of them have adapted very, very well. Now, the next question I want to address is, so what specific challenges are there when operating on older patients? So is surgery different when operating on an adult, on older patient as compared to a young one? So we all know that if we leave syndactyles alone, you may get a length discrepancy. It's not so bad in the third web space. Here you can see the middle finger a little bit bent, but overall this is still okay, doing not too bad. Sometimes you can have more deformities, especially in the distal phalanx, if you leave them alone. And so this will be a more difficult surgery because there's more deformity at the DIP joint. If this has been operated much earlier, maybe some of these deformities could have been avoided. Now, when I do syndactyles in earlier, sort of a younger child, my preferred age for syndactyly release is 1 year. And the reason is because I can usually get away with graftless syndactyly release. The fingers are shorter, the flap design is simpler. I can usually just not need any skin grafts at all. Now, the moment they hit 3 or 4, this is a 4-year-old child, I usually start thinking differently. I will usually expect to use skin graft because the fingers are longer, and I use smaller flaps so that if I do end up in raw areas, they are smaller. So actually, the consideration is different even between a 1 and 4 year old in something like syndactyly. On the whole, I think surgery in an adult or a child is the same. You just need to use different instruments. You may need to consider plating. You may need to think about there's a higher chance of non-union. These are all examples of real polydactyly that has been left. You may need to use saw, whereas in the younger child, you can just use knives or osteotomes. You just need to think about all these things and consider all this extra instrumentation. But other than that, I think most of the surgeries are the same. But we'll look at a few other examples as I come to this last question. What will happen to these children as they grow much older? Now, there really isn't a lot of literature about children beyond the age of 18. We often congratulate ourselves when we get a 2 to 3 year follow-up for our surgeries. If you can get up to 18, that is a real achievement. Now, what happens when they hit their 30s, 40s, 50s, or reach old age? There really isn't very much at all. So just looking at this on the new on the web just now. So a lot of sort of unreleased syndactyly. This family 140 members pass between generations. Now, what happens if you don't release syndactyly? You probably think that nothing much would happen. Now, we had published a very interesting case report a long time ago. This is an untreated syndactyly. This is an incomplete syndactyly where the fingers are rubbing against each other. So we see an incomplete syndactyly. Sometimes we don't release this. But in this instance, the constant friction led to a marginal ulcer and squamous cell carcinoma. So that's something I always bear in the back of my mind. When I see an adult with incomplete syndactyly, I will check the web space to see whether there's any frictional changes. This is a very interesting paper. It's just been published in the European Journal Hand Surgery. It's from the Finnish group. They look at a mean follow-up period of 18.2 years. And they look at the quality of life and problems after syndactyly separation. And they found on the whole that uncomplicated cases as compared to complex syndactyly has significantly better patient-reported outcomes, better functional scores and cosmetic scores. Now, what was very, very revealing was that these patients continue to have pain when they were 18, 16 to 18% reporting some pain the last week. And I think it's very, very intriguing to find out why they have pain. I suppose this is specific to their syndactyly. Now, this is an interesting man who presented when he was 45. He has a cleft hand that was untreated. And I think because the cleft was not closed, he ended up now with a radial collateral ligament instability because the thumb is constantly trying to get across to the little finger. So because of that, really, these are some problems that are only unveiled when they are much older. In this case, we use tendon reconstruction to stabilize the radial collateral ligament. And this is something that may be done. Now, you can argue, therefore, this could have been prevented if the cleft was closed when he was much younger. We often say that it's a functional triumph but social disaster. Maybe it's not always a functional triumph because you got to think about these things when they are much older. This is another patient we presented with ulnar dysplasia. I think when he was much older, younger, he had a rotational osteotomy and separation of his syndactyly here. But now at 38, because of the constant movement of his ulnar digit, he's developed osteoarthritis at this level and quite a lot of pain at this joint. And then we got to think what we're going to do now. Should we do another rotational osteotomy? Should we do an arthroplasty? And in this case, what was done was arthrodesis, a straightforward arthrodesis with arthrax staplers. And hopefully that will take away the pain, but we're not sure whether that will really inhibit his function. So these are all things that we don't know until they are much older. Now, let me just end with this. I mentioned earlier that I had the privilege of seeing thalidomide children and adults when they become much older. So we published this study a few years ago where we did a survey of the existing thalidomide survivors, and we managed to get quite a good response, 127 respondents with a mean age of 58. And it is an anonymous survey, so we were not able to get the exact diagnosis, but we asked them to describe their deformities, and we were able to get quite a good idea of what the deformities were. 77% had some form of phoconelia, 45% had radial clad head, which is very, very big numbers. 73% with thumb, 55% with finger deformities. Only 50% underwent surgery as children. Now, this was really very revealing. The mean quick dash was 54.3. This is a very, very high quick dash. That means they have significant disability, the majority of them. And the quick dash also correlated with a worsening EQ5D. That means a lot of them had a very poor quality of health. And interestingly, the worst quick dash and worst EQ5D correlated with those who had radio deficiency, finger changes, or multiple differences. Just some of the problems we picked up when we were surveying this and seeing some of these older patients. If you have a radio deficiency, you're not able to get really excellent pronal supination, and you often use your shoulder to compensate. And what they often end up with is a reverse shoulder deformity and lots of pain in the shoulder joint. Again, you won't know this until you follow them up for much older. And a lot of them had neuropathic pain and carpal tunnel compression. If you're going to release the carpal tunnel in this patient, you really got to be very careful where the median nerve is because the anatomy is totally different. So in summary, late presentation implies that's the ideal time for surgery, but there really is no concrete evidence. We need to do more studies on this. There are many reasons for presenting late, and it's important to find out why some of this can be corrected. Late presentation may not always be a problem because the patient adapts very well. And this is a very interesting area of study as well. There are specific challenges when operating on older patients, so be prepared for the right instrumentation, especially. And there's very little research into what happens to them when they grow much older. I welcome you all to the IFSSH in 2028. Please mark these dates in your calendar. Thank you.
Thank you. Thank you very much, Dr. William. Thank you for your great talk about the congenital hand problems in adults and the late presentation. So the question on the chat from Nazri. Thank you very much for your question. What are your recommendations for choosing and rehabilitation of finger polycization in adults? Any surgical power in these cases?
Yeah, it's an excellent question. If it's a congenital thumb hypoplasia, I would not do a polycization for that reason that I showed just now. Somehow the index fingers can adapt and become like a thumb without surgery. For traumatic cases with amputation at the CMC joint, that may be the only solution, or you can do a toe to thumb transfer with a big iliac bone graft, so on and so forth. But in these patients, if I do a finger index polycization, I want them that the braid, they will always perceive the polycized index finger as the index finger. It's very hard for them to think of it as a thumb following a polycization. The next question is the cleft hand with radial collateral laxity. Does the patient still have a good pin strength? I didn't measure it formally, but I think the pin strength is much better because the thumb is more stable.
Okay. Any other questions? This might be a question unrelated to your main topic, but I also provide surgical support in low to middle income countries. Some patients develop post-operative severe contractures while they stop coming to the hospital after the surgery. Severe contractures can lead to another problem. Have you had similar experiences in Cambodia?
Yeah, so I showed that case of the syndactally release. So the syndactally release, if especially if you don't do it properly, you will get that severe contraction. You will get that wet creep. A lot of them will not seek help because they thought, this is it. It was operated. There's nothing much that can be done. If you get a post-thumb radial polydactyly deviation, I guess in some of these countries they will just accept it. Whereas in probably Western countries or in Japan or Singapore, they will complain if it's a little bit of deviation. So I think patients' expectations are so different.
Yeah. Okay. Any other questions? Okay. So thank you, Dr. William. And next speaker is Dr. Scott Oishi. Talk about overgrowth conditions.
Okay, good morning, everybody. Oh, it's morning here. I guess afternoon in a lot of places, but morning here. Let me see if I can share my screen here.
Okay. Yes.
Can everybody see my screen
Yeah.
and hear me okay?
Please go ahead.
Okay, good. So let's see. What we're going to talk about is overgrowth conditions in general and treating macrodactyly because we just have a short period of time to talk about it. Let's see. So I have nothing to disclose regarding this, but if you look at sort of what we're talking about in overgrowth, especially nowadays, it's really related to this PIK3CA spectrum, or so-called the PROS, PIK3CA related overgrowth spectrum. And this table is actually a really good one that was published back in 2015, which sort of shows everything that can be related, to this. And if you look at sort of all these things are all on that spectrum of having a PIK3CA mutation. Things can be very tissue specific. So like this muscular hemihypertrophy, which is pretty classic in its presentation. Some things that really are phenotypically severe with not much tissue specificity like cloves, which is this congenital lipomatous overgrowth, vascular lesions, epidermal lesions, and skeletal dysplasias. And what we're going to talk about today was macrodactyly, which in the terms of being specific can be very specific, and phenotypic severity, although they list on the low side, as you know, if you've seen these patients, can be very severe. So this PIK3CA mutation is really what's called a post-zygotic somatic mutation. So it's not genetic. Many parents obviously want to know who was the cause of it. Is it genetically related? And this is not. So it's something that happens after the embryo is fertilized. And what's very interesting about it is if you look at it clinically, you can see something like this, which for people who have seen a lot of overgrowth, you can look at this hand and this form right away know that this is this muscular hemihypertrophy. And the reason you know that is not only is the limb big, but if you look in the hand, the metacarpals are splayed because of the overgrowth of the muscle. And if you look really closely in the palm, you see that you're losing some of those lines. And the reason is that many times there's not normal fascia holding muscle in, and the muscle is so large that it leads to sort of the overgrowth and loss of some of those lines. And this is a case of that really sort of phenotypic severity, not much tissue specificity called cloves. So this kid has that congenital lipomatous overgrowth, has some vascular low flow lesions, epidermal lesions, skeletal dysplasias, but just generalized overgrowth. And it's interesting in how it affects some tissues and not the rest. And what we're really going to talk about today is macrodactyly. So when I saw this child, she was very, very young, a few weeks old. And already you can see the really disproportionate overgrowth that involves the thumb and index finger. And we're really going to look at this. And if you look carefully at this hand, it also is a pretty severe one because you can look in the forearm, it's already large too. So it has accompanying what we call macrodystrophic lipomatosis. Are there things that you can do short of surgery? So a long time ago, not a long time, many years ago, they started treating these kids or thought maybe we should treat them with some kind of mTOR blocker because of that pathway that we showed earlier. So that was either sirolimus or everolimus, so rapamycin basically. And it's a potent immunosuppressive and really does have anti-proliferative properties. and doesn't inhibit the mTOR receptor. And again, if you look at this, this is just another diagrammatic representation of it. But the upregulation in this is really this PI3K. And as it goes through this overgrowth spectrum, it hits what's called this mTOR receptor. And so that's where rapamycin works. But you can tell that it's not very specific because it actually blocks all of this also. And so as a result, back in 2018, Vino et al. In Nature published something about a targeted PIK3CA blockage. So the name for it is alpelisib, but it's targeted therapy that can block the PIK3CA related overgrowth. There still continues to be a lot of debate about who should be put on, when you put them on, why you put them on, and how long you put them on, especially in young children. Although they report, and some people report very good results, I think the jury's still out. And many people think that in some of these kids and some of these children or patients that are affected with overgrowth, that perhaps there's another mutation. It's not just a mutation of PIK3CA. But what are some of the reasons that you wouldn't want to treat all these overgrowth patients medically? Potential morbidities, of course, and the laboratory abnormalities can exist, like hypertriglyceridemia, which many of them get, hypercholesterolemia, neutropenia, and anemia. They frequently get this mucositis and have to be monitored pretty close for it, and over long-term risk of malignancy. And in fact, as surgeons, we don't want to treat that. So I have my hematologist treat it, and many of them or some of them are very hesitant because they've seen the alpelisib that they think may sort of stunt a little bit of their growth. And the other thing is we don't really know what the level is. So everything has a level. So if you give them rapamycin or give them alpelisib, what number or what level do they look for? Nobody really knows what number that is. So a lot of work's still going on into efficacy of this, who really should get it, and when they should get it. But what we're going to try to focus on today is really macrodactyly because of the short period of time we have. But as that picture shows there, it's a very frustrating problem. You tear your hair out because, again, it's like who needs surgery? What surgery do you really want to do? And what can be the expected outcome in these patients? And there's a big spectrum of disease, right? So some of these kids, they walk in like this, and you can see that really it's affecting the ulnar side of the hand, which is fairly unusual. So it's the little finger predominantly and not much in the radial side, which is usually what you see. And you can kind of predict that this patient is going to do well long term. You can still see there's some good extensor creases. The finger might be a little big, but probably will not need anything done. As opposed to a child that comes in like this, which is the more common scenario. And what's really fascinating to me, actually, in macrodactyly and overgrowth is if you look at this child, right, it's affecting the thumb, index, and middle finger, so the median distribution of the hand. But it's also, if you look, it's a clear demarcation of the overgrowth in the palm. So you can see how this is affected in the palm. But on the ulnar side, what do you see? You see normal ring and little finger along with sort of the proximal soft tissue in the palm. And the way this affects certain tissues and not some tissues is sort of interesting and very fascinating to me, although it doesn't really help you clinically. It's just sort of fascinating finding. So what do you do for this problem? So we published this in Journal Hand Surgery European back in 2019. But really what you try to look for is when the patient's finger gets to be the same size as the same-sex parent. And if it's not, usually you can wait on it. When it gets to be the same size as the parent, then you have sort of options about what to do and whether that includes shutting down the growth plates alone, so epiphysedesis, if there's angulation, do some osteotomies. When the finger, and you don't get these kids until they're bigger, what do you do? So if it's a bigger fingertip, you can sort of debulk, shorten, fuse, do something to sort of make it smaller. But the overall width is very hard to treat, although there have been some reports more recently of people trying to do that with fairly good results, I think, that I've seen when I've reviewed those manuscripts. I certainly have not tried to decrease the width in terms of taking bone out, because I'm not sure how that is a successful surgery. If we look at surgical options, there's epiphysedesis, somehow correct the angulation, shorten through the bone, shorten through a DIP, sort of reduce the nail, because many of them have thick nails, and try to really try to decrease the bulk for the patients. So most will have sensation. So when you're debulking along the side of the finger, it's okay to actually remove the underlying sensory nerve, and they still have sensation at the tip of the finger. And you'll see that the digital nerve in these kids is really large in the affected digits. And nobody really knows, it's a chicken or egg. Did the digital nerve start being enlarged first, and that's what caused everything else? Or was it a secondary result to the mutation in the area? Interestingly, when we send off tissue to have it studied, the tissue that you send off to have genetically studied for the PIK3CA mutation, the most reliable tissue to have a positive diagnosis is the nerve and also the subcutaneous fat, much higher than if you say send tendon or bone. What you have to be very careful for these kids is that they have a compressive neuropathy because the nerve itself can be very big, and they can also have abnormal scars or keloids. And so if you look at these kids, besides doing some sort of debulking of tips, what can happen is they can get carpal tunnel really bad. So the children will come in and you'll see them shaking their hand, or they'll be biting their hand, or the parents will say, oh, they wake up at night complaining of pain, or look like they're having pain. They shake their hand frequently. If you hear about that, or that they're biting their fingers quite a bit, the young children won't tell you that they have typical symptoms of carpal tunnel. And so you have to be really cognizant of these kids that have macrodactyly, that many of them, if not, most of them will need some sort of carpal tunnel release. And when you open them, believe it or not, this is what the nerve looks like. It's a lipofibromatous hamartoma. And this is a classic sort of appearance of it. Never biopsy this because that's what it's going to be, is a lipofibromatous hamartoma. And you can, in fact, give them a really bad neuroma if you try to biopsy this at all. The hard part of this is that make sure you step cut the carpal ligament to try to get it closed again. Sometimes you even need a little rotational flap to get some coverage over that. In terms of what you do to debulk, what we try to do is come up one side of the finger, and actually, as you've shown here, you're taking out the skin and subcutaneous tissue. Make sure you try to design these flaps. It's very tempting to really pull on it, really get a lot of tension on the skin, and don't do that because these kids tend to make a lot of scar and tend to make a lot of problems with wound healing. So try to make the incisions as loose as you can when they can close. But actually, angular correction to the bone can be performed, and where you do these corrections just kind of depends on whether they're at the size of their same-sex parent. So if they're at the same size, you can actually go right through the area of the physis to make your osteotomies. If they're not, you can do extra-articular osteotomies. Actually, that's very good about correcting angulation. Sometimes they actually recur if you do them at a young age, so these children sometimes need several surgeries for this. A lot of them get sort of hyperextension of their tips of their fingers. And so when you do this, you can also go in there and sort of do flexion osteotomies of the distal phalanx to sort of decrease the bulk at it. What's really important is that when you make these incisions, to make little darts in them like this to break up the scars of the joints, because again, a straight line scar in this area can form significant contractures and also lead to hypertrophic scarring and also wound problems. And when you're taking out this tissue, again, you're taking out the skin subcutaneous tissue and also usually the sensory nerve that underlies it. It's kind of scary the first time you do it, but actually, because most of the time you're taking out or many times taking out the digital artery at the same time, and the fingers will live. Just make sure you don't do it, obviously, on both sides of the finger at the same time. But it's really, again, important to make these sort of darts and notches at the IP joints. And again, angular deformity can be corrected. But the other thing is that when you want to decrease the tip of the finger's nail, you sort of can do sort of incisions like this, where you're coming actually through part of the nail plate and germinal matrix and underlying nail bed, and sort of closing this down to try to get a better shape of the tip of the finger and also debulk at the same time. And again, you'll notice that there is incision over the carpal tunnel because, again, many of these patients, they'll have that history of biting and shaking their hands. So really be cognizant of the young child that carpal tunnel release may be required at the same setting. And when in doubt, you should release that carpal tunnel. But some kids that you can't do it, and you can't do anything to debulk them. And I would argue that this child that has what we call sort of grotesque macrodactyly, these fingers are going to be avoided by the child. Even when you see him, he'll be pinching between that thumb and little ring finger. And the best thing for him is going to be sort of ray amputation, and it lets them go on with their life, and they do very well with it. I know it's very difficult, especially in Asia, to convince sort of the parents to do that. But long term, it's going to be the best thing for the child. And what I do is I have actually video of children who had this done, and it makes it a lot easier for the parents to see, sort of post-operative video of how the patients use the hand as opposed to the way they're using them at the present setting with all these large digits. So something like that, it comes in and they want them separated and they want them smaller. But really, all you're going to do with that is create a lot of problem for that child, in my opinion. Again, interesting, look at this hand. Again, the thumb and index and middle finger are really involved along with the palm. And as you go to the ulnar side, the ring and little finger are normal, along with a normal sort of proximal area. It's a very fascinating problem. And again, look at this. I mean, you can understand that these will never be functional fingers. But when you go in there, this is just to show how big that digital nerve can be. So this child is probably about a year and a half or so. And you can see how large that digital nerve is, probably 5 to 10 times the size of a regular digital nerve. That's how big these nerves are. And the bone can be very, very large, as you've seen before. But functionally, if you look at these children, he's going to be much better off sort of with having those digits gone. He's got very good function in his hand now. He later had to have something done for his thumb, which is very common, where we do flexion osteotomies to put it in a better plane for his use. But he obviously has much better use of his hand now that those big digits are gone. And you could never get this result, in my opinion, if you tried to sort of debulk them or separate the syndactyles. The real problems that you have to talk to the parents about is not only one, I think, abnormal scar potential, but also that you need to talk to them ahead of time that the digits will never be normal, and have realistic goals and expectations that they will follow, because many of them think that you're going to be able to make it normal, and you will not be able to make it normal. And it's really important for them to know that ahead of time. And occasionally, sometimes when they have big time scarring or you get keloid scarring, we put them on a short course of methotrexate, about 6 to 8 weeks, which we found to be very effective in sort of modulating this sort of keloid scarring, not only in this condition, but also in conditions like syndactyly, when you sort of have those rare cases that get it. Thanks for your attention, and thank you for the opportunity of participating in this webinar.
Okay, thank you, Dr. Oishi, and thank you for your wonderful talk, even in early morning in Dallas.
Yeah, not too early yet.
Thank you. And do you have any questions? William?
Scott, thanks for the talk. It's very, very helpful as usual. The muscular hemihypertrophy, do you operate on those?
We try not to. Because the reason I say that is because we've tried. I mean, you can try to debulk the muscle, but not only do they have overgrowth of the sort of normal muscle, but they have overgrowth of muscles you never even heard of. So when you open up this palm, it's fairly. I think you actually have a good picture of that. I think I saw it at our last meeting. I think, don't you? But they get these big muscles, and we've tried to debulk them, but they come back. If anything, those are the ones I really push to go to hematologists, and have had pretty good luck if they put on rapamycin or Pellicip to sort of slow the process down. I have tried to operate on them because they have a lot of splaying in the metacarpal, so I've tried to do osteotomies on them. To me, it hasn't been very successful. I don't know if you have a different result from that, but have not been very successful at that. I think some thumb operations can be very successful, so I will operate on their thumb to try to do flexion osteotomies and put them in a better position for use.
I guess the really interesting thing about that condition, Scott, is that the PIK3CA mutation, we're thinking bigger muscles, bigger tissues, whereas in this condition, there are more muscles, there are aberrant muscles. What are your thoughts on that? Is it the same pathway? Is it an mTOR thing? How can you get more muscles with an mTOR mutation?
Yeah, that's interesting. I don't have the complete answer to that, but when I send the it is a PIK3CA because when I operate on those children, I take muscle, and I send it, and most times we have to send some of the muscle. We have to have our hematologist, oncologist will not start people on medication without a positive PIK3CA biopsy or genetic studies. And so when you send that tissue for the muscle, I mean, I guess I haven't had a negative one. When you have that hemihypertrophy condition and you send that muscle, it comes back as a PIK3CA mutation. Was that the question? Yeah.
Yeah.
I don't know what your thoughts on it are. And I don't know why you have de novo muscle, but there's certainly muscle that exists in the palm, if not the forearm, that, we never, I mean, at least I've never heard of them, they're different than like Ganser's muscle, same thing like that. I don't know what to call them.
Sure. I don't know. That's why I'm asking you.
Yeah.
My hypothesis is that they are embryonic muscles. They are sort of part of the whole evolutionary sort of lineage. I mean, obviously, I can't prove that, but that to me sounds like a logical thought process to explore.
Mm-hmm.
Yeah,
Definitely.
Okay. Okay. And some questions in the chat. Oh, thank you, Bob. Thank you for your questions. Can we reduce the size of median nerve at carpal tunnel?
Well, if you try to operate in if you try to operate in that nerve, you're going to give them a bad neuroma, and you have more strands and they're also really big. I don't think I mean, I've never heard of someone trying to decrease it. I think somebody at one point has tried to excise it and to graft it, and some of it looks like they've had some recurrence from it. So I don't think you can really decrease the size of the nerve. You just have to do carpal tunnel releases on them.
Okay. And is there any role of toe transfer as alternative to reamputation?
Is there a role of what?
Role of toe transfer as alternative to
Oh, yes.
reamputation?
Well, you would do an amputation plus a toe transfer. Yes, I mean, I think you could. I mean, there's been a couple reports. I think Neil Ford Jones is the one that did it in the literature that when you transfer it, you think the thought I had was that you haven't changed the milieu of there and the mutation still exists and the toe will get bigger. But there's been a couple reports of transferring a toe in that area and it hasn't got big, has not got big. So I think that may be an option.
Okay. And any role of ribamycin for pre or post surgery?
For rapamycin?
Yes. Yeah.
Yeah. So, some of these children, especially the ones that have really big macrodactylies, they get put on rapamycin and you have to stop it about a week before. So yes, there are patients that are on it and we try to get a continuum on it afterwards. Probably more so nowadays you would put them on a Pelacib, which is the PIK3CA specific blocker, because I think it's more of a specific blocker for what the upregulation is. But again, it's tricky. I know that Vanot and his group in France are really hot and putting everybody on it, but we don't really know what the dosage should be, what the level in your blood should be to adequately treat this, how to measure response. I mean, right now it's a difficult thing to know what the exact dosage is, but certainly people that have this sort of grotesque macrodactyly, or they show up as a young infant and they have huge limbs, I think should be considered pretty soon for starting on some kind of medication.
Okay. And since what age can medication be started for macrodactyly?
Well, it's a good question. Our hematologist oncologists won't start them before about 6 months of age, and even for them, that's really early. Most of them, they won't start to about a year of age.
Okay. Okay. Any other questions? Okay.
Scott, I got another question if that's okay. So, digital macrodactyly. So you mentioned you can take out the nerve if you're going to take out the overlying skin, and they're okay. The sensation is okay and stuff. Would you proactively take out the nerve, thinking that could be the source of the pathology and recurrence in the foot, especially in the macrodactyly toes? Would you preemptively just take out the nerves?
Well, usually if I'm doing that, I'm operating them because, well, Yes, the answer is yes, but usually I'm there anyway because I'm debulking them. So if I debulk them, I'm taking out that nerve for sure.
You just take out the nerve because you think that that may be the recurrence, or
Right, and usually you can trace the nerve back to where it gets to be more normal. You know,
Okay.
where it comes off the common. Because again, you know, like you're asking, and I think it's a really good question, is we don't know what came first. Was it the big nerve that caused all this, or did the underlying mutation cause the big nerve? And I don't think we know that. So I think it's worthwhile taking out the nerve because, as you know, if you send the nerve and or fat, that gives you the highest rate of finding the genetic mutation in that tissue. It's, you know, up over 70, I can't remember the number, 78% or something like that. So that's the best tissue to send because it shows the mutation in the highest rate. Yeah.
Yeah. Thank you.
Mhm.
Any other questions? Okay. Great. That brings us to the end of this webinar. Thank you so much for being interactive, and thank you to my panel, Massimo, and Scott. Thank you very much.
Thank you. Have a good day.
Thank you.
Thank
Hi,
you.
Scott. Hi. Hi, see you. Hi, Takehiko.
Bye-bye.
Bye.
Bye. Thank you. Thank you very much. Thank you all. Oh, thank you, Jen. Thank you.